Okay, wonderful students. Now we're going to talk about disability and chronic illness. Okay, so definitions of disability. The World Health Organization back in 2001 classified functioning's disability and health as a dynamic between a person's health condition and their environment. And then luckily our government back in 1990 passed the Americans with Disability Act, and what that literally says is anybody with a physical or mental impairment where it substantially limits one or more major life activity, they would be classified and protected under the American with Disabilities Act to be provided with accommodations to ensure that they have an equal ground to succeed, right? And so if there is a physical or mental impairment that substantially limits their ability to do any type of major life event, then we as part of society says to these individuals, we'll help you get what you need in place, whatever that looks like, and we'll talk about it in this lecture, to ensure that you have the same chance to succeed as everyone else. Approximately 61 million people in the U.S. currently have disabilities, and that number is expected to rise. 20%, that is 20% of the people in the U.S. 10% have a significant and severe disability. And then it is expected that up to half will have a disability within the next decade. Developmental disabilities are a group of conditions due to an impairment in the patient's physical, learning, language, or behavior areas. These conditions begin during the developmental period and may impact day-to-day functioning and usually last throughout that person's entire lifetime. Acquired disabilities is a disability that has developed during the person's lifetime, for example, as a result of an accident or an illness, rather than a disability that the person was born with, right? Acquired disabilities can be visible or they can be invisible, right? And then age-related, people may have disabilities related to age when there is an inability to perform certain tasks due to degenerative changes related to age. So their inability to perform certain tasks, again, due to those degenerative changes. So what are these age-related disabilities? It might be hypertension, high cholesterol, diabetes, osteoarthritis, heart disease, gait and mobility issues, falls, respiratory infections, COPD, urinary incontinence, hearing and vision loss, dementia. All of these are examples of these types of conditions. Chronic illnesses refers to human experience of living with a chronic disease or condition. The person's perception of the experience and the person's and others' responses to the chronic disease or conditions would be classified under chronic illness. Americans living in rural communities are more likely to have chronic illness, and chronic illnesses are the leading causes of death and disability here in the U.S. Disability is a physical or mental condition that limits the person's movement, senses, or activities. They can be congenital, for example, like cystic fibrosis, or they can be acquired at some point in your life, like lupus, right? A chronic health condition can be a disability, but not all disabilities are chronic health conditions. Let me repeat that. A chronic health condition can be a disability, but not all disabilities are chronic health conditions. Excuse me. Medical conditions or health problems with associated symptoms or disabilities that require long-term management are considered chronic diseases or conditions, right? They are persistent for months or years rather than days or weeks. The U.S. National Center of Health Statistics states that chronic disease is lasting 3 or more months. Okay, so if it is going to be considered chronic versus acute, it has to be longer than 3 months. Okay, 3 or more months. The World Health Organization classified it as long-lasting conditions that can usually be controlled but not cured. And chronic diseases and conditions, both of those share the characteristics of being irreversible, having a prolonged course, and are unlikely to resolve on their own, right, spontaneously. Incidence of chronic conditions occurs in people of every age, every socioeconomic level, every culture. We have people fall into these, right? Medical conditions or health problems with associated symptoms that require long-term management, 3 months or longer, is considered chronic conditions. Conditions, again, that do not resolve on their own, or that aren't curable, right? Or I should say, cures are rare. And then management. People must learn to live with the symptoms or the disabilities, or they need to learn how to carry out lifestyle changes or treatment regimens for these chronic conditions, right? The prevalence of chronic conditions occurs again in every age group, every socioeconomic level, every race, every culture. Most frequently occurring for 7 to 10 accounting for about 7 to 10 leading causes of death in the U.S. So again, 7 out of 10 leading causes of death in the U.S. is caused by chronic conditions. And we've talked about what some of those are, heart disease being a big one, right? Chronic conditions are responsible for 2/3 of all deaths globally. Has to do with cardiovascular disease, diabetes mellitus, chronic lung infections, cancers, right? And we see an increasing prevalence in lower income populations, right? It makes sense because these populations don't have access to as many resources as the rest of the population, and those resources include eating healthier foods, having access to medical care, medications, preventive care, all of those things, right? 1 of 4 adults has 2 or more chronic health conditions, and the complexity of care increases over time. Risk for conflicting medical advice, therefore, is greater as these multiple chronic conditions expand and exacerbate, because you end up being on multiple medications and you have multiple adverse reactions and effects from those medications. And many times patients, especially the elderly, are on multiple meds that aren't even necessary at the time. And could be, a result of having duplicative efforts, right? And so with multiple chronic conditions, this is going to cause, again, one condition exacerbating the other, right? And then because you have multiple conditions, that the cost of care is going to increase because you have more meds, more doctor visits, and on, more hospitalizations, all of those things, right? So causes of the increase in chronic conditions. What is it? So we have a decrease in the mortality from infectious diseases, right? That's one variable. Lifestyle factors are definitely a variable. Obesity, right? We know that, especially in the U.S., the percentage of obese patients has gotten significantly more overweight as well, right? So even just overweight all the way through morbid obesity patients today, there are many, many more percentage-wise. I think it's almost up to 50% where are overweight, right? But we know that number is growing every year. Longer lifespans. We are living longer, right? So as a result of living longer, we're going to have more chronic diseases. That makes sense. And we have better improved screenings, better diagnostics, which lends to the whole living longer, and also the cost increase with chronic illnesses, right? Managing chronic illness involves more than treating the medical problem itself, right? Because it involves different phases of that medical disease and processes over that person's lifetime, right? And that person must learn how to adapt not only to the the chronic condition itself, but also to the meds and the side effects of those meds and all of the variables that go along with that. So persistent adherence to therapeutic regimens needs to be a factor that patients need to understand. They're going to need to be persistent and thorough in their therapeutic regimens, right? Because one chronic disease condition can lead into another chronic disease condition real quick if it's not being managed effectively by the patient, right? And we know that chronic diseases don't just affect the patient themselves, but it affects the entire family, the entire, it could affect, peers, friends, you name it, right? Okay, question. When is a medical condition considered chronic? A, 1 month, B, 3 months, C, 1 day, or D, 3 days? Well, we know it's 3 months, right? So B. Okay. Interface model is based on the life experience of the person with the disability, and it views disability at the intersection of the medical diagnosis of a disability and the environmental barriers that disabled person is having to deal with, right? So again, the person with a disability, rather than others, defines the problem and seeks direct solutions. So that's the interface model. The medical model views disability as resulting from an individual person's physical or mental limitations and is not connected to the social or geographic environments. Medical model focuses on finding a cure. So our health experts are looking to fix the problem, basically. Rehab model is closely focused on the belief that a person with a disability makes an effort and works with rehab services, then they can overcome their disability. So again, rehabilitation model focuses on the belief that if a person with a disability makes an effort and works with rehab services, then they can overcome their disability. And the summary of the psychosocial model is the analysis is one where there is a holistic approach of how the disability impacts the individual. So sickness and disability are best overcome by an appropriate combination of healthcare, rehabilitation, personal efforts, and social work and adjustments. Okay? Is the following statement true or false? Disability is the loss or abnormality of psychological, physiological, or anatomical structure or function at the organ level. And I would say false. Impairment is what that is. Impairment is the loss or abnormality of the psychological, physiologic, or anatomical structure or function at the organ. Disability is the restriction or lack of ability to perform an activity in a normal manner, right? Good. Does the patient require or prefer special accommodations? These are questions that we need to ask to ensure that we're providing quality care, right? Or are there any special accommodations to communicate with my patient? Are those needed? Are there efforts being made to direct all conversations to the patient rather than the people who are accompanying the patient, whether that's friends, family, those kinds of things, right? Are healthcare facilities accessible as legally required, per ADA accommodations? Has accessibility been verified by the person with the disability? Is a sign language interpreter or someone available who can interpret for the patient? Does the facility have appropriate equipment to provide health care for people with disabilities? The health promotion model aims to explain the factors underlying motivation to engage in health promoting behaviors, and it focuses on people's interactions with their physical and interpersonal environments during their attempts to improve their health. Health promotion models are focused on exploring people's attitudes about health and individual experiences related to it. According to the theory, one would have to look at people's lifestyles, their psychological health, and social and cultural environments to understand most of their health related decisions. Do not neglect health promotion issues of our patients, as these are important. We need to ensure that the patient has a healthy diet, that they are exercising regularly, that they get social interaction frequently and satisfactorily, and that they have access to and are making great preventative health screening decisions and making that a priority in their life. Person first language emphasizes the person before the disability. For example, person who is blind or people with spinal cord injuries. Identify first language puts the disability first in the description. For example, disabled or autistic. The person, not the illness, is the most important. The use of person first language may provide a means to separate the individual from their diagnoses or their impairment. Referring to a group of children, though, as children with Down syndrome rather than Down syndrome children is one example of a person first language, right? So group of children or children with Down syndrome. Disability increases with age. This is largely due to the biological changes that are associated with aging that we have gone over in class. For example, such as reduction in bone density, reduction in muscle density. There's less subcutaneous tissue fat. We know that the digestion slows down, all of those variables, right? Advancing age is the major risk factor for a number of chronic diseases in humans. Age-related functional decline among people with disabilities is a chronic and complex problem that is challenging to manage. Ideally, reversible factors could be identified and addressed appropriately as early as possible. However, the complexity of aging with disabilities makes it difficult for long-term survivors with disabilities to receive appropriate medical care. 3 kinds of consequences between aging and disability exist. The first one is disability-related secondary conditions. People with disabilities are more likely to develop secondary conditions, either directly or indirectly, which are similar to those that aging people experience in general. But they occur 20 to 25 years earlier and are often referred to as premature or atypical. Number 2, age-related conditions. These conditions are related to aging and the long-term consequences of being exposed to environmental risks, as well as the effects of poor health behaviors that may be experienced by aging persons and also by aging persons with disabilities, right? So like hypertension, high cholesterol, diabetes, osteoarthritis, heart disease, falls, gait mobility issues, respiratory infections, COPD, urinary incontinence, osteoporosis, hearing and vision loss. All of those are examples. And number 3, multiple chronic conditions. The risk of having 2 or more chronic conditions at the same time, either in dyads, like hypertension and diabetes, or triads, like cholesterol goes with hypertension and diabetes, right? Those are more likely to exist, right? And finally, we also have to consider that aging of our caretakers is also a problem, as our patients are aging as well, right? So the aging of our caretakers that are caring for those patients with disabilities. Management of chronic conditions. Patients do learn to live with their symptoms or their disabilities. That is a factor, and they do learn to live with the side effects for the treatments of those disabilities or conditions, right? Because we know medications have a lot of side effects that go along with them that we have to sometimes learn to deal with, right? And our goal, of course, is to control the chronic conditions, prevent them from exacerbating, and prevent them from causing complications, right? And this involves day-to-day management of their illness. Eating healthy and taking their preventive meds and doing and preventive exercise, all of those things, right? And it does take that second bullet point. Management of chronic conditions is a process of discovery. That is a true nomer, because every med doesn't work for every patient. They work differently in different people's bodies. So sometimes it does take time to discover what works for one patient and what works for another, right? It also, financial burden is a variable that comes into play, especially with the elderly many times, because they're on fixed incomes. There are ethical issues that are intertwined with dealing with medical and chronic conditions. And we do mean living with chronic condition means living with uncertainty at many times, right? It's a fact. Chronic disease management involves managing the symptoms of long-term diseases, thereby allowing patients to enjoy life as much as they possibly can. Through managing their chronic diseases, providers can help slow down the progression of their chronic disease and help control the symptoms. So again, that patients can take back control of their life and enjoy their life. One of the best ways to prevent and manage chronic diseases is to maintain a healthy diet. For example, making simple dietary changes such as consuming less sodium by reducing the amount of packaged processed food in a diet can help patients manage or prevent high blood pressure. We also look at lifestyle changes like drinking alcohol, only drink one glass of wine, and not as frequent, working out, exercising, getting their flu vaccinations, pneumonia vaccinations, right? Ensuring that we have a quality of life, health promotion behaviors, all of those things, right? Challenges with living with chronic illnesses. Obviously, alleviating and managing their chronic disease symptoms. That's always a challenge, right? And then the psychological impact of chronic illness and chronic pain. It has a big, big impact on our patients, right? And also, what about physically accommodating the disabilities? That can be very challenging for them, right? Preventing complications or managing crises as they arise, and managing complications as they arise. That can be very challenging. Patients carrying out regimens given by the doctor, that can be challenging at times. It can be challenging for a number of variables. What if the regimen the doctor wants the patient to carry out is expensive and they can't afford it, right? The patient's not going to take the meds, but they're not going to share that many times with the doctor because they're embarrassed, right? But they should share it so that we could look at more cost-effective measures, right? Validating the individual's worth in relation also to family functioning, right? So we need to be able to show the patient we hear their concerns, their personal concerns, and we do validate their self-worth as we're showing the family and the family unit that they're important too, right? And then if a patient's chronic disease is threatening what they consider their identity, they're losing themselves in the fact that they have leukemia, right? So they get diagnosed all of a sudden with blood cancer, leukemia, and they're kind of losing who they are because they're engulfed in the sorrow and desperation and disbelief that they have this, right? That is part of chronic illness. That is something that we need to help the patients cope with, right? It is important that we normalize the personal and family life of these patients. We help teach them how coping strategies and different community resources that can help them with the normalization of what's happening in their life. We want to make sure that they're not staying socially by themselves and becoming isolated, and that they're still intermingling with their family and friends, and they're getting out of the home and they're not lonely and all of those things. And if they are variables, we're doing things to get them connected to resources in the communities. Establishing those networks of support, finding resources if in fact, they can't afford their meds. Well, there's a lot of discount coupon programs out there. There's a lot of PCPs that have samples they can give to their patients. There's all kinds of things out there, right? We need to help them find those, right? We need to return them to what they consider a satisfactory way of life so that they can enjoy their life, right? And if it is relevant, ensuring that they die with dignity, without pain, and without anxiety, right? So what is the trajectory model of chronic illness? So the illness trajectory contains the physiological unfolding of a patient's disease. So basically the disease course. It involves the actions and interactions that shape or control the course trajectory, as well as the emotional impact of that illness on the persons involved, right? So that's the sickness trajectory. We need to establish and prioritize our goals. We need to have a plan of action to achieve the desired outcomes, right? And our interventions need to focus on the pieces that we can control of the symptoms, signs and symptoms. We need to focus on avoiding any potential complications. And we need to focus on the psychosocial effects and the patient's quality of life, right? And we need to evaluate the outcomes again, and evaluate the outcomes and then reassess the problem and see if we didn't meet our objectives, then figure out where exactly did things break down and go back and fix those, right? Okay, end of the PowerPoint is a NCLEX question. True or false? Telehealth or telehome health, use of electronic data and telecommunication technologies to support long distance clinical health care is not suitable for patients with chronic illness. Is that true or false? I would say absolutely false, right? We use telehealth effectively for providing patients, chronic patients. It's a great method of communication. You can live in one state and telehealth and manage someone's health in another state. We do it all the time. All right, so this is the end of this